So we talk about mechanical ventilation. We're really talking about doing two things. Removing carbon dioxide, which is one of the functions of the lung, and deliver oxygen. That combination of ventilation and oxygenation are really two separate issues, but often in many patients they kind of go together. We want to reduce the carbon dioxide level because we know that as it elevates will lead to a acidemia developing, and that's not something we want. There are really three different reasons why we would need to ventilate somebody primarily. One is that the work of breathing associated with spontaneous ventilation is so excessive that they can't keep up with it. Either the airway resistance has been elevated so high, or their lung compliance has fallen so low that the amount of work required by the respiratory muscles to generate a tidal volume is so excessive that the patient can't keep up, and they fail. Okay? So an asthmatic whose airway resistance becomes so excessive, their secretions and their diameter of the lumen of their airways becomes so narrow that they can't breathe. The baby who has the loss of compliance because of the lack of surfactant being present. So are all examples of where you would end up having either a compliance or resistance problem. Third reason, or maybe the second reason, depending on how you want to look at that, is a neuromuscular issue. Either the brain itself, those respiratory centers we talked about in the brain, the apneustic center, the pneumothoracic center, the medulla oblongata, there's damage to those centers so that the ability to ventilate isn't there. Or the spinal column has been damaged. And where do the phrenic nerves exit the spinal column? C3 to C5. Remember that? So if there is some damage to the neck at that level, you can end up having a loss of diaphragmatic innervation, and therefore lack of ventilation. And you can also have just damage to or there's some disease states which alter the ability of the impulses to travel down the nerve to the diaphragm. And we'll talk about Guillain-Barré and polio and all of those kind of things as we go through this. And then finally, there's just a prophylactic mechanism whereby somebody who's elderly, who's having anesthesia done, post-operatively, the anesthesiologist chooses not to be aggressive in reversing that agent and just allowing it to naturally wear off, but they need to be ventilated for a short time after that point. Post-op open heart patients are classic examples of that. Ordinarily, good lungs, the problem is that they just had to have some cardiac surgery, so come out post-operatively, we're going to support them for a few hours until they start waking up, and then we just go ahead and extubate them. So those are problems with ventilation. Separately, you can have problems solely with oxygenation. If you remember back, carbon dioxide is 20 times more diffusible across the alveolar capillary membrane than oxygen is. So you may have situations where you just have an oxygenation problem, but not necessarily an alveolar ventilation problem. Okay? Two separate issues, but they both require you to be ventilated. And we would see the oxygenation, the idea is to increase the arterial oxygen tension as well as the saturation. And usually the problem is a large shunt is what is causing that problem. So, positive pressure ventilation is typically the method that we end up using. Instead of having you spontaneously create negative intrathoracic pressure, drawing air in, I'm going to use a positive pressure mechanism to push the air in. That increase in airway pressure, though, although it does allow for effective ventilation, it ain't benign. Bad things happen all the time. One of which is that positive pressure in the intrathoracic space prevents the blood from returning back to the heart. So blood that is in the abdomen, blood that is in the brain, does not come back to the heart because the positive pressure is keeping it out. If you remember, spontaneous breath, that negative intrathoracic pressure actually acts as a vacuum to pull the blood back. As we decrease the cardiac output, because I've decreased the preload, oh God, there's those words, I end up having a reduction in renal perfusion also. So the body actually starts to retain water, and actually it thinks that the patient's hypovolemic. It thinks that the patient's blood volume is low, so it goes ahead and restores volume. Sorry. My daughter. And then, because you're not returning blood from the brain, you can end up having problems where you end up having increase in intracranial pressure. Aside from the effects of positive pressure, you also can have problems with the artificial airway. Okay, I think I might have told you that I had reviewed cases for defense firms for respiratory therapists that were being sued. One issue that occurs is the development of a tension pneumothorax while the patient's on a ventilator because of that reason, increased airway pressure. Two has to do with airway problems. Patient whose artificial airway, that's their life support mechanism, you have to have, something goes wrong with that airway. Either accidental extubation, or the cuff pressure is too excessive, so we end up having some tracheal damage. It becomes kinked or clogged, and no one notices for whatever reason, and the patient has an untoward effect. The third reason, by the way, is blood gas, or the third cause of a respiratory therapist to typically be sued is because of something related to a blood gas puncture, complications secondary to that. So, put them on a ventilator is not just, a wonderful thing and everything is hunky-dory. You end up having a lot of times the cure is almost worse than the disease that's there. So, got to take it into effect. All right, positive versus negative. Two different approaches to ventilation. Virtually all the ventilators we use now, the ones sitting on the wall there, are all positive pressure ventilators. I'm actively creating a positive pressure related to the lung pressure, so gas moves from the ventilator into the patient. There is the option we have of doing a negative pressure ventilation where I create a vacuum outside the chest wall and it pulls the chest wall out and air rushes in. So I create a negative pressure within the intrathoracic space. Iron lungs are your typical example of that. We can talk about invasive ventilation versus non-invasive. Invasive ventilation is the ventilation we do when we put an endotracheal or tracheostomy tube in. Non-invasive ventilation is one where we're using a mask of some kind. So we're not intubating the patient, but we're able to ventilate. There's pros and cons to both. There's pros and cons to positive and negative too, for that matter. The real essence of this, though, is what type of focus are we going to have when we're delivering a breath? And there's two primary ways to approach positive pressure ventilation. I can focus on giving a fixed tidal volume that's consistent from breath to breath, or I can focus on limiting the airway pressure to a preset threshold, and that's constant from breath to breath. Let me talk about each of these in a sec. When you focus on a volume-based breath, the pressure required to deliver that volume varies on a breath-by-breath basis based upon lung mechanics. What's the airway resistance? What's the lung compliance? As the lung compliance goes down, the lung gets stiffer. To deliver that same volume is going to require more pressure. Make sense? If I'm delivering in a pressure-based breath, where the pressure the ventilator generates is constant from breath to breath, if compliance falls, tidal volume is going to fall. because now that same pressure can't deliver as much gas. Does that make sense? Okay. So we're going to find that there's two schools of thought on how to ventilate patients. Some are volume-oriented, some are pressure-oriented. Which is better? Yes.
It depends.
They both have, I can ventilate any patient in either way, but I just have to know what the effects of changing compliance and resistance are going to end up having. Okay? So they're both good, and they both have their flaws, as we'll find. Okay? And they both require hopefully a competent caregiver at the bedside to take care of them, to recognize when things aren't going right. Emily?
Can you repeat the pressure method again?
Sure. With a pressure-based breath, pressure remains constant. So changes in compliance and resistance will have a change in volume being delivered. As airway resistance goes up or lung compliance goes down, you're going to have less tidal volume delivered. Okay? So we want to be able to monitor the tidal volume to see when these effects are happening. In a volume-based breath, as compliance goes down or resistance goes up, airway pressure is going to go up. It's going to require more pressure to deliver it. I'm going to get that volume in, hell or high water. Well, okay, but you don't want to put so much pressure that we end up causing a pneumothorax. So it's a line you walk and you choose. And as we'll find, there's actually a third one, but we're not going to talk about it right now. Okay. There's a way to kind of merge the two of them together. But volume orientation, pressure orientation. We also then can have the ventilator set up so that its reaction with the patient can be in a couple different ways as far as who is in control. This is called the mode, and the mode typically are one of three things. One is called AC, or assist/control. Assist, control. And with the assist control mode, when the patient wants a breath, they trigger the ventilator on, create a little negative inspiratory pressure, or generate some inspiratory flow, and the ventilator senses that the patient is there, wants a breath, and delivers a full breath to them. Okay? So if I had my tidal volume set to a certain level, the ventilator sensed that the patient wanted a breath, it assists them by delivering that full tidal volume to them. If they are apneic and not triggering the ventilator on, the control portion would say, based upon the respiratory rate, okay, it's been 5 seconds since the last breath you took, I'm going to go ahead and give you a breath. So there's a minimum number of breaths that are always going to be delivered. If the patient wants an additional one, he gets an additional full tidal volume breath, or full pressure breath. So far, so good? Okay, that's what we call assist control. That's full ventilatory support. Okay. Other end of the spectrum is called spontaneous. And as you might guess, this means the ventilator doesn't do anything. It's the patient breathing. Okay? And in this sense, all of the patient's minute ventilation is being done by them. So you have to have somebody who has an intact respiratory drive. You can't have somebody who's paralyzed and be on spontaneous. Then there's the middle ground. Kind of a combination of both. And that's will be what SIMV is for. And let me go slow on this one. S is for synchronized. Let's do it together. We're all synchronized. I is for intermittent. M is for mandatory. And V is for ventilation. Good Lord Almighty. Synchronized, intermittent, mandatory ventilation. With AC, if I have a backup rate of 12, the patient will get 12 breaths per minute at whatever desired tidal volume or desired pressure I want, and they'll do that forever until we take them off. If they want 14 breaths per minute, okay, go ahead. You'll get 14 of those full tidal volumes or full pressures. With SIMV, what was created, or the reason why it was there, was we used this as a weaning mode. So in this case, we would have a certain number of mandatory breaths, and all the rest of the breaths would be spontaneous. So if I had somebody on, let's say, SIMV of 10 times a minute, they had a mandatory breath delivered. The full tidal volume, or full pressure, whichever focus we have. In the meantime, or in between those breaths, they can do whatever they want. If they want to take a little spontaneous breath on their own, okay. And then we used to do this when we would wean patients. We would drop the rate to 8. And then we dropped the rate to 6. And then we dropped the rate to 4. We dropped the rate to 2. And slowly, they took up more of the overall minute ventilation because of their spontaneous breathing and less from the mandatory breaths. Okay. Typically, we don't utilize that method of weaning. We don't really wean anymore. I think I talked about this. We just liberate. We evaluate them in the morning and say, are you ready to come off today? And if they are, we take them off. If not, we put them back on and try it tomorrow. Okay. Overall, the goal is to get alveolar minute ventilation adequate enough so that the patient's PCO2 doesn't rise. So they can normalize their PCO2, either through whichever method we want to end up using. So, remember back that it's an inverse relationship between alveolar minute ventilation and PCO2. Increase the alveolar minute ventilation, decrease the CO2, and vice versa. That minute ventilation is the tidal volume less the dead space volume times the rate. So that alveolar minute ventilation can be affected by the tidal volume that is generated, by the dead space which is present, and by the respiratory rate. Usually, well, anatomic dead space doesn't change, but there are two other types of ventilation. Do you have boxes on yours, or do you have a letter there? Okay. V without Q, right? Okay. So there is some mechanical dead space that we add, things like suction catheters and adapters and monitors and that kind of stuff. And then there's also alveolar dead space, which can be created just simply because of alterations in ventilation and perfusion ratios. Normally, we alter minute ventilation by changing the rate or the tidal volume. So that's what we're going to end up doing. How much tidal volume do we use? Well, if you remember back, normal spontaneous tidal volume is somewhere between 5 and 8. When we put a patient on a ventilator, we usually, this is kind of evolving as we speak. More and more places are going with that 5 to 8 milliliter tidal volume for everybody. Okay, we used to use much larger tidal volumes. When I was in school, we used about 12 to 15 cc's per kilo. Big tidal volume. Gradually, then it's gone down and down and down, and now we're probably in that 5 to 8 range again. Okay. Once I generate that, and again, that's based upon ideal body weight, not actual body weight. We're going to go ahead and watch the static compliance to see if that's an appropriate level. If you have problems oxygenating and it's not a problem with ventilation necessarily, you need to go back and figure out what the cause is and fix that. If I have a barometric problem issue, move. Move off the mountain. If I have a problem with hypoventilation because perhaps the respiratory centers are depressed, ventilate them. It's an easy one to fix. You know, the drug overdose who comes in breathing at a respiratory rate of 4. They're probably going to need to have some ventilation done. VQ imbalance responds very well to oxygen levels being increased. Diffusion defect usually is just temporary because of widening of that gradient. If it's permanent, there's not much you can do about it. And the big one is the application of intrapulmonary or the development of an intrapulmonary shunt that you need to reinflate those alveoli somehow or other. So, fixing the oxygen level can be done a couple different ways. So if my PaO2 is low, I can increase the FiO2. That's one way. But there's also an alteration in how the breath is delivered that can affect the PaO2. Specifically, increasing the mean airway pressure. Again, not something we're going to calculate, but the ventilators will tell you what the mean airway pressure is. It's the average pressure that is present on a breath-to-breath basis. I call it the space under the table. The more space you put under the table, the more oxygen delivery you can end up having. I can make my table here's my table, right? I can make this is the mean airway pressure, right? I can make that higher by adding PEEP. Because now all of this is included also. Raising the baseline. Adding PEEP will raise the mean airway pressure, which will then improve oxygenation. I can make the table taller, which will raise the mean airway pressure. And finally, I can make the table longer, which will raise the mean airway pressure. Which one you choose kind of depends upon the clinical situation that you're working with. Certain things will respond better to one than to another. But they all will work, especially in those situations where raising the FiO2 isn't cutting it. Like in a patient who has a shunt as the primary cause of the hypoxemia. You need to look at something else. So here's my table. I can raise the baseline, the PEEP level. I can raise the top, the PIP, peak inspiratory pressure, or I can lengthen the inspiratory time by prolonging the breath in some fashion. Yes, thank you. Because I feel like I'm making no sense.
If a patient is like, we have to choose from one of these three things, do we just pick and choose, or do we know, like, in this situation?
You'll find that in this situation, raising the PIP works better. In this situation, raising the PEEP works better. So it's just basically based upon the pathophysiology that's causing it. Okay. Sometimes it's preference too, to be honest with you. Take that volume versus pressure orientation we talked about at the beginning. Up until about 10 years ago, all adults were ventilated with volume orientation. Rarely did you ever see a pressure-based breath being used. Then people got a little more comfortable with pressure and they started doing it. But some docs said, I'm not changing. I'm going to stick with volume-based ventilation. The new application, the new modes that we have, the new ways that we can ventilate patients are more and more taking this and expanding on it. So it's been a real hard battle in a lot of institutions to get docs to buy into this newer stuff because they didn't learn it when they were in medical school. Hello? Yeah, you didn't, because the technology wasn't there. So there's a far better way that we can approach an ARDS patient today than there was 10 years ago, 20 years ago. Okay? The real problem is more just the acceptance by physicians than it is by, and to some extent, therapists too. You know, I have to learn something? Are you kidding me? But the improvements have reduced more mortality as time has gone on, so it does make a difference. Okay? A couple other things. COPD and asthma. Kind of different ones because these pathologies, the underlying lung damage, we can actually make things worse because of what we do, and sometimes it just makes sense to not be aggressive with them. For instance, using tidal volume to control alveolar minute ventilation is probably not your best option. Rather, use the respiratory rate to be able to work with. Also, if I increase the rate, and think about this for a second, if I go from a rate of 12 to a rate of 15, at a rate of 12, what is my total cycle time? 5 seconds. 60 divided by 12, right? At 15, what is my total cycle time? 4 seconds, right? So by increasing the rate just by 3 breaths per minute, I shorten the total cycle time I can have. Okay. Well, part of that cycle time has to be inspiration, and part of that cycle time has to be expiration. When we put a patient on a ventilator, we fix that inspiratory time. So if I have an inspiratory time of 1 second, and I go from a rate of 12 to 15, I now have reduced expiratory time from 4 to 3 seconds. That doesn't sound like much, but patients with airflow limitation can't get the air out. That 3 seconds may be inadequate to fully empty the breath out. So I'm putting 700 milliliters in, but I'm only getting back out 600. Well, eventually that's going to catch up with you. Okay, that's trapped gas. Raises the risk of barotrauma, raises the pressure that is needed to ventilate, because I got trapped gas now. So it's imperative that we pay attention to that inspiratory and expiratory time that is there. There are certain patients who are so difficult to ventilate that the only way we can is to pharmacologically paralyze them. Control them that way. Okay. And there is an approach, something called permissive hypercapnia. Their CO2 is higher than normal. They're acidotic. Okay. We'll live with it. We'll accept the fact that they're slightly hypercapnic, they're slightly acidotic, because going up on the ventilator settings further raises the risk of barotrauma, raises the risk of hypotension. So we'll just leave well enough alone. Okay. And remember too, we only want to correct these folks' oxygen, at least the COPD patients, their oxygenation only up to about 60. After that, they don't need to be hyperoxemic. As long as it's above 60, they're on the flat part of the curve. We'll do good. Okay, so let's have a little scenario here for you. I have have a 5'10" male admitted to the ICU. Put this patient on the ventilator. Okay. And this is if I haven't said it before, this is what your final PE will be over the summer. I will tell you that you have, a 5'10" male. Set up your ventilator settings, your alarm settings, your apnea parameters. Call me when you're ready. Well, what mode do we want to put them in? Typically, if a patient needs to be placed on a ventilator, they need full support to start with. So which ventilator mode gave us full support? Assist control. Okay, so that's my mode. What size tidal volume do I want to have? 5 to 8 based upon the ideal body weight. How do I figure out the ideal body weight for a 5'10" individual, male? There you go. 5'10" is 70 inches. So 10 times 6 is 60, plus 106 is 166. Make that into kilos is probably about 50, 51 kilos. So take my tidal volume somewhere between 5 times that 51 and 8 times that 51. Okay. We would then determine what the minute volume is, and I'll go through a method for that at another time. But if I know what minute volume I want to have, and I know what my tidal volume is, I can determine what respiratory rate I need to set the ventilator at to accomplish that. Whenever we put a patient on a ventilator, at least for our purposes over the summer and really for right now too, we're going to start everybody on 100%. I can always drop it, but it's easier to set it high to begin with, get a good PO2 back, and then go down from there. Short-term wise, it's not going to kill anybody. And as far as levels of PEEP, we usually put a small amount of PEEP on, 3 to 5 centimeters of water, just to start with. The argument is, and whether or not it's true or not is open to debate, during your expiratory phase, your epiglottis actually closes, so that, and your vocal cords close, so you end up having a little bit of back pressure that is there. By putting it in the tracheal tube you take that away. It's called physiological PEEP. So a little bit of PEEP can hurt. 3 to 5 centimeters of water. So I put my patient on the ventilator. I get these blood gas values back. How would we classify this? Don't all go at once. It's okay. It's a respiratory acidosis that is uncompensated with border of mild, moderate hypoxemia, right? Okay. How am I going to fix this guy? What parameters would I change on the ventilator to improve that acid base and oxygenation status? Well, he's on 100%, right? So I can't go up on the FiO2. Okay, well let's take the oxygenation first. Okay. Can't go up on the FiO2. What's our other options? Increase the mean airway pressure by increasing PEEP, or inspiratory time. Easiest thing to do is just add a little more PEEP. Okay. Now, the other thing just to bear in mind here a little bit, if I correct this, that's going to go up just naturally by itself. If I reduce the alveolar PCO2, I can increase the alveolar PaO2, P capital AO2, right? So, how am I going to fix that PCO2? We can increase the rate. So if I started at 12, put the rate to 14, put the PEEP to, if we started at, let's say, 5, let's put the PEEP to 7 and see what ends up happening. Repeat blood gas is this. PaO2 still needs to have some work done on it. Okay. Now, many people, and depending upon the pathology you deal with, 60 is good. 60 is good enough. But for our purposes, we want to get back to somewhat closer to normal. We can go up on the people a little bit more. Okay. So long as we're not seeing other complications from it. And we'll talk more about that over the summer.
And so can we increase PEP at that time, like the second time?
You can. You would probably increase the PIP by increasing the tidal. If I was doing a volume-based breath, which we were, you would probably raise the tidal volume to accomplish that. Because remember, in a volume-based breath, the pressure is variable. So to raise the PIP, you have to raise the tidal volume to be able to get to that point. That just looks wrong. All right, let me